We can go ahead and get started. We'll see whoever else wanders in. Thanks for being here. I mean, this was a tough time slot. So I thought that potential could be 0, but 2, that's terrific. So I'll introduce myself and sort of share a little bit of background. So I'm Phil Magidson. I'm an emergency medicine physician and geriatrician from Baltimore, Maryland. I spent most of my time in the emergency department, but did some additional, I did a combined residency and did a geriatric fellowship as well. So sort of think about ways we can sort of improve the care of older adults, and have really sort of been thinking about capacity assessments for a while. I think that's something we see in the emergency department, you know, a fair amount with all different types of patients, but particularly older adults. So the goal, so sort of 3 objectives. One, just sort of outline sort of patient capacity assessments. I don't think that that first bullet point is sort of all, you know, sort of new. I have sort of a 4-step approach for capacity assessments, and I think really bullet point 1 and 2 is sort of extrapolatable to all patients, but the focus today is sort of thinking about nuances with some older adults, with older adult patients. So we'll sort of focus in on older adult patients. I'm not an attorney, I'm a physician, and I recognize that, as you know, we all work in different states and different hospitals with policies and procedures, and I appreciate that. So what we talk about here is going to have to overlay on that, but we are just going to talk as doctors, not as like policymakers, not as attorneys, but I recognize we don't practice in a silo. So I think, you know, some of what we'll discuss has, you know, administrative and legal implications as well. So just 3 cases to sort of frame the discussion. So the first case is Miss A. She has moderate dementia. She's coming into the emergency department with her 2 daughters, Pam, with whom she lives, and Joan. Joan lives out of state, but Pam called her sister and was like, Mom is wandering in the middle of the night, and I'm just like, I don't know what to do. I need you to come in and sort of help me out. And sort of things came to a point in the middle of the night where she was found out in the neighborhood at 2 in the morning. They didn't know where else to go, so they brought her into the emergency room. Of course, Miss A has no advance directives, never sort of completed anything. She doesn't want to be there, but she is confused. She doesn't really know what's going on. She's never identified a power of attorney, a healthcare decision maker. You don't think she can make a decision. Her daughter Pam is like, I've been trying to take care of Mom for about 1.5 years. She definitely needs to be admitted. Her sister Joan, who just flew in, says, Ma, maybe we can do this okay at home. Miss A looks to you, Pam looks to you, Joan looks to you, the medical student looks to you. Who's going to make this decision? Who could possibly be someone who could decide? Can Miss A even identify a surrogate? So you're sort of thinking about that. You're pulled into the room with a 72-year-old gentleman who's coming in after a syncopal episode. So he had an exertional syncopal episode. On your exam. You notice a crescendo, decrescendo systolic ejection. Remember your concern for aortic stenosis. You think he needs to be admitted. You notice in the chart there's something about him being incapacitated, and you say, I really think you should stay in the hospital. And he says, there's no way I'm staying in the hospital. My granddaughter is graduating high school next week, and I am not missing that graduation. His son says, he was here 1 year ago. He was very sick in the ICU. I made his decisions. I have all the paperwork to prove it, and I want him admitted to the hospital. So again, they both sort of look to you. Does he stay? Does he go? Who's going to make sort of that decision? The last case is a 92-year-old gentleman who comes into the emergency department, brought in by the fire department. He lives independently in an apartment building. Neighbors had called because there was a little bit of smoke coming underneath his door. Fire department breaks in. There's food on the stove that had been forgotten about. This gentleman was just asleep in the next room. So brought into the emergency department. You notice that he's been admitted a couple of times over the past 6 months for some confusion, for some falls. You notice a son listed as the point of contact who's out of town. You call his son. He says, we know Dad has worsening dementia, and I'm flying in 2 days. We're going to get him in an assisted living facility. I'm sure he doesn't want to be admitted to the hospital. Can you just send him home? I'm sure he'll be fine for the next 2 days. I'll be right there. So I'm sort of thinking about these. So I think these are not otherworldly cases, and in fact, all of them are true scenarios, things that these I've absolutely encountered, and I think we encounter similar scenarios in sort of our day-to-day. Just a couple of definitional things. So competence, I think sometimes we'll sort of conflate competence and capacity. Competence is a legal definition determined by a court, not something that we're doing. Perhaps our notes, our records, our testimony may inform a court, but we are determining capacity. And it's really important. Capacity relates to a specific medical decision at a specific point in time with respect to a specific situation. And as such, it's not global in scope and it's not static. And that's going to be one sort of reoccurring theme, sort of take-home points. The key elements, and I think this is not brand new, and we're not going to, one could spend a long time talking about all of these in detail, but there's sort of 4 key elements, really sort of communicating a choice, understanding of relevant information. I really sort of think of that as sort of the facts that you present to a patient in a patient-centered approach, sort of what are the facts of your presentation, of your illness, of your diagnosis. Appreciation, the best way to frame this that I found is sort of, and these are the facts, and this is why you came, right? So sort of how does it apply to the situation at hand? Your doctor referred you in because he was concerned about labs. You came in because you were having these symptoms, right? This is sort of how it is relevant to sort of the situation at hand. And then reasoning, a patient has to have some sort of internally consistent reasoning. We may not always think it's good reasoning, but it has to be sort of consistent for them and ideally sort of seen throughout the chart that they've consistently used this reasoning. And I think actually decision-making capacity, we do this informally all the time. We don't ask these 4 questions, but just sort of normal conversations with patients, I think we're doing that all the time. But sometimes we do have to sort of pause when it's an important decision or we're not certain the patient has a full understanding and sort of go through it a bit more formally. So who can do that? So I think you can get adjunctive help from neurology or psychiatry or geriatrics, but in the emergency department, I think ideally you are the best person to do that, right? So capacity, again, relates to a specific medical decision at a specific point in time with respect to a specific situation. And in the emergency department, I think emergency medicine physicians are best to understand what is sort of ongoing with respect to that capacity decision. And so I would encourage you not to sort of punt that responsibility. I think others can provide perhaps helpful adjunctive information, but really emergency medicine physicians in the emergency department are best at determining capacity. And so what is sort of the approach that I have? Do you have to sort of go through the MMSE or the MOCA or these various other tools and scales? And the answer is no. If these are known, perhaps that's helpful. But there's really sort of a 4-step approach, or what I would describe as your task, in conducting a capacity assessment. And the first is establishing trust, and we'll talk a little bit more about that. Asking about those 4 key elements that I outlined, considering the sliding scale principle, which is not a diabetes management principle. We'll talk a little bit more about that. And then keeping a record of sort of your medical decision making and being able to do that succinctly and quickly and accurately, and I'll at least share how I do that. So as far as establishing trust, I think sometimes these conversations can start off a little confrontational because it may be in the setting of, you wanting to do something, the patient doesn't want to do something, right? So they just say, I want to go, I don't want to, I'm fine, isn't it obvious, I have rights, you can't force me. And so sometimes these things sort of start off in that manner. I usually start with, my goal is I'm here as an advisor, right? I'm not here to force you. I'm just simply sharing information and going to provide advice. And my goal or aim is to do what you want to do. And I don't promise that we're going to do what you want to do, especially if I'm not certain they have capacity. But I think it is true that ideally we want our patients to be pleased with what we're doing, right? We want everyone on board. That makes for the easiest patient encounter. So it is my aim. And so I think just sort of framing that up front certainly is helpful. Asking about or sort of going over sort of the 4 key elements of a capacity assessment is important to sort of, again, make sure someone could communicate a choice. I think that's generally obvious. I say if a patient can't really consistently keep the same choice so that you can put it into play, then I would say they're not communicating a choice. Certainly an obtunded patient can't communicate a choice. Again, understanding is sort of those facts, appreciation, I sort of frame within the context of, and you have come here because of X, Y, or Z. And then again, sort of internally consistent reasoning. The S in your task is the sliding scale principle. And so this is described sort of in the medical literature and sort of the medical ethics literature as really sort of the rigor and sort of comparing to what's sort of at stake. And again, I will give you 2 examples that I think sort of frame this fairly concretely. If you're going to disagree with someone and you want someone to do something they don't want to, what sort of degree are you going to go to make sure that that is, sort of put into place? And so the example I will give is a number of years ago, a patient had a hand laceration, it needed sutures, and he said, I don't want any sutures because I don't want to get lead poisoning. Okay, and I don't think there's lead in sutures, right? And so I said, there's no lead in sutures. His father had died from lead poisoning years ago from sutures. Okay, I don't know whether that's true or not. There's no lead in the sutures. I think you need sutures. He said he didn't want them. I would say the stakes were sort of lower for a simple laceration. That's not a guy I'm going to sedate, I'm going to tie to the bed and do sutures. And so, although his reasoning was not perfect, maybe it was internally consistent for him. Maybe he was under the impression that's why his father died, fine. I thought the reasoning was not great, but the rigor, I thought we at least met it. I'm not going to sedate him, we're not going to do sutures. So be it. I think another example, and a slightly different example, is an epidural hematoma, right? A completely functional person who has an acute epidermal hematoma. That's a high morbidity, high mortality condition that we can absolutely intervene upon. And if someone comes in who is completely functional with a discovered epidural hematoma and a neurosurgeon at the bedside ready to do something and they don't want a procedure, they better have a darn good explanation as to why, right? We need to make sure they understand, they appreciate the situation and have good reasoning, because this maybe is a person I would sedate and restrain if they don't have good sort of reasoning. So that's sort of the sliding scale principle, is I think sort of considering it within the context, sort of what really is at stake. And then keeping a good medical record of these conversations, right? These are sort of high-risk conversations. There's often a lot at stake. There's, as I said, when you start the conversation, sometimes there can be a little bit of conflict. So we have Epic at where I work, my shop. And so I have a dot phrase that I have made that really sort of outlines, right, the specific question that we're discussing. So often it's leaving against medical advice. I put in the 4 components, the 4 sort of key elements. And again, this is often just, it's helpful to document, but it's also a good reminder to me as I'm going through, okay, did I explain it clearly? Do I know that they have an understanding? Do they appreciate sort of what's going on? Have they provided reasoning? And sort of can go through those elements. Oftentimes there's some other sort of issue. They have cognitive impairment, considering their sort of cultural or religious beliefs, making sure that I have considered that. And then ultimately deciding, do they have capacity for this specific question at this specific time? And so filling this out is probably under 10 seconds. And again, right, this is a relatively high stakes discussion. And not only I think that this provides sort of a good framework of sort of that discussion and why I sort of reached the conclusion that I reached, but it also reminds me of sort of those 4 key components. So let's revisit our 3 patients. So as a refresher, Miss A comes in with her 2 daughters. She has advancing dementia. She's living at home and really sort of needs a different sort of environment. She doesn't want to be admitted. We don't think she has a good understanding of what's going on. She says she's got to get to work tomorrow. She's retired, 30 plus years ago. She has 1 daughter with whom she lives, 1 daughter who is visiting. She's never identified a surrogate decision maker. And I think, one question is, could Miss A identify a surrogate decision maker? Could she identify one of her 2 daughters to potentially, make decisions if she's not able to? And again, we need to consider this as a specific question at a specific point in time with respect to a specific situation. I doubt Miss A could consent to a Whipple procedure, right? But I think she could identify a surrogate decision maker. And so, establishing trust with her, with that posture, might be sort of challenging. But I think sort of framing it as, you got a great family, you have 2 great daughters, and we want to really, make decisions that work for you, but let's say you can't make a decision. Let's say you're sick and you're not able to answer our questions. Who of your daughters might be someone you would look to, or who would you look to? And, Miss I might say, well, my daughter Pam lives with me. Pam knows, she takes me to my appointments, and Joni's in visiting from out of town. She's got a big family and a job, and she doesn't really know all of my details. I love them both, but I really think Pam would be the best to make that decision if I couldn't speak for myself. I think with respect to this decision, right, you have 2 doting daughters at the bedside who might not be perfectly aligned, but probably it would be hard to go wrong with picking either of them. So I would say the stakes are a little lower here. And I think that's actually good reasoning, right? I mean, she lives with her daughter, Pam. The other daughter, Joan, is visiting from out of town. And I think with respect to this decision, I would say Ms. A with her moderate dementia can identify a surrogate decision maker. And I would take full advantage of that and make sure that is well documented, because with her moderate dementia, she may reach a point in relatively short order where she can't identify someone. And now there's no one in the medical record, and that can really be an issue. So I think really sort of documenting that and making sure that that is clear, that this patient can, she's identified her daughter, Pam, who can make these decisions, and make sure that we sort of have that clearly there. Again, I don't think Ms. A can consent to a Whipple, but as far as identifying a surrogate decision maker, I think that makes sense. So this was our second patient. He presented after an exertional syncopal episode. We think he has critical aortic stenosis. He was in the hospital about a year ago, very sick in the ICU. There's this incapacity question in his chart, but he feels fine today. He's passed out a couple of times. He doesn't want to be admitted. He wants to go to his granddaughter's high school graduation. His son, well-meaning, but says, you know what, no, I made decisions when Dad was in the hospital last time. I have paperwork here. I want him admitted. They're both sort of looking to you. And again, right, the specific question is about hospitalization at this point. And the time is now. It is not a year ago when he was critically ill in the intensive care unit. At Hopkins, where I work, we have this incapacity flag on the banner. I don't know if other places have that. Sometimes that can just sort of live there whenever someone is marked as incapacitated, and it's just sort of assumed moving forward. So he was marked as incapacitated when he was in the ICU and intubated. Okay, that makes sense. This is a completely different situation, a completely different time. I'm glad his son is at the bedside, but with respect to making this decision, I think we really do have to look towards the patient. So I think establishing trust and framing it within, we want you to make it to your granddaughter's graduation in a week, but also to her next graduation, right? And sort of just doing your best to frame, and establish trust and frame why you want him hospitalized. He has good understanding of what you're saying, and the valve is tight, and I understand that that's probably why, I'm passing out, but I only do it every other month or so, and the graduation is next week, and it's really important to me, and I really want to go to that. So as far as the sliding scale principle, I would say there's moderate stakes. I mean, that's not necessarily someone who you want to send out ideally, but he makes a good point. He hasn't passed out for 8 weeks, and it is next week. So I don't think it's a great decision, but I think with respect to this decision about hospitalization at this point in time, I think he has decisional-making capacity, right? And I think this one is a little more clear, but sometimes people will get hung up, or I have noticed, and even relatively recently we had a case where people will get hung up on, well, what was decided previously? Who is the decision-maker previously? Well, it depends. The scenario could be completely different, and in this case, it is different. So I would say this is a patient who could leave against medical advice, but I would encourage him to stay. All right, how about our last patient? This was a case maybe I had 2 or 3 months ago. So this is a 91-year-old gentleman, lives by himself. A fire department was called because there was smoke coming under his apartment door. Food was on the stove. He was asleep in the bed, didn't realize what was going on. Fortunately, he wasn't injured, no smoke inhalation. We were able to identify that his son is an out of state, has been identified as the decision maker. And so we were on the phone with the son. The patient doesn't want to stay. We don't think there's a safe discharge. And so, again, sort of thinking about the specific question, is this patient safe to go home with respect to this specific scenario, this time? Patient doesn't want to stay. His son says he'll be there in 2 days. I'll be there in 48 hours. I think Dad can go home just fine. You'll do your best to establish trust with him. He was very pleasant, but just really had no idea what was going on. He says, it couldn't have possibly been me to leave the food on the stove. My wife does the cooking. His wife had passed away 10 years ago, didn't even remember that. He is definitely not in a position to make any decisions. His son, again, sort of wants him to go home. What's at stake? I would say the stakes are really high, right? He lives in an apartment building. He may kill himself, but also everyone else if he goes home. So the stakes are extraordinarily high. And I certainly appreciate that his son wants to be involved. I don't think the patient has capacity, right? He's telling us he doesn't want to stay. He doesn't like being in the hospital. Okay, decent reason. He's communicating a choice, has no appreciation or understanding of what's going on. He doesn't have capacity to make that. And I would say that his son, who is not there, I appreciate his input and his availability, but I don't think he is really acting in the best interest of the patient. Not maliciously, but sending his father home in this scenario is just not the thing to do. If his son was there at the bedside and I'm going to take dad home, I'm going to be with him, that may be a different scenario. But we really sort of have to consider all of the facts, everything sort of in front of us, and consider what's in the best interest of the patient. My wife is a neonatologist, and this comes up, I think, relatively regularly in the NICU, where there is a disagreement about a child being discharged home or not with parents, and there is sort of immediate involvement of other authorities, right? We don't necessarily do this as much, but it's okay if you really do not believe that someone is acting in the patient's best interest, as this being one of those scenarios, to say, I appreciate you, commenting and being available, but we're not going to be able to do that. Your dad can't go home. We're going to admit him. When you get here in 2 days, he's going to be in the hospital. I think one of the things to really sort of emphasize, and it's not completely unique about older adults, but capacity is not global in scope and it's not static. And older adults, they're often in the hospital, critically ill, and then they're back home and they have great family caregivers, or maybe they don't, and there's cognitive impairment. You really have to consider the specific scenario, right? Capacity relates to a specific question at a specific time with respect to a specific situation. And preservation of autonomy and independence is very important to older adults, important to everyone, but particularly important to older adults. And so considering that capacity assessment, again, sort of at this point in time with respect to this situation, this question is important. I think we are best at determining capacity in the emergency department. Sometimes it's a big ask, and it's fine to involve other people if you must, but when it comes to emergency medicine decisions, treatment, plans, dispositions, we're best at doing that. And so I would just encourage you not to sort of punt that responsibility. 4 steps, your task and capacity assessments, establishing trust, asking about those 4 key elements, communicating a choice, understanding, making sure the patient appreciates what's going on and how it applies to them, and making sure they have sound, internally consistent reasoning, considering that sliding scale principle, what's really at stake, and then having a sort of a clear, concise way to document those discussions. So I will pause there. And I am impressed with you all making it to the last didactic session of SAEM 2024. Happy to take questions. Comments, questions? Sure. We can. Yeah, we can. You have to, you can recapacitate someone. It just takes a couple of clicks. But I think sometimes there's a little bit of just inertia of like, oh, well, I don't know, there's a yellow incapacity flag, like they can't do that or they can't do this. And actually, if you go into it, you can sort of see when it was, put up. And so sometimes it'll be like a year ago. Okay, you go back a year ago, there's a discharge summary from a 32-day MICU stay. Okay, well, that makes sense. But we can update them, yeah.
Thank you for responding for the
Sure.
And they do get conflated, obviously. So, what happens when you have a patient who, from a neurocognitive standpoint, obviously cannot make decisions? And I guess at that point in time, when they hit a certain neurocognitive deterioration point, that capacity could, be onward.
Mm-hmm.
Is there any way to designate that? Because then it's not really dynamic.
Yeah, I certainly hear what you're saying. And I think there are, right? There's some patients who, you come into the room and it's clear they can't make any decision whatsoever at all. I don't know that there is necessarily a specific way to designate that. And I would hesitate in making that designation, because I think like when that threshold is reached, like what is that threshold? I don't know what that threshold is. And, you know, just because someone scores 18 out of 30 on a MOCA, does that mean they can't identify their son as a decision maker and it's 7, you know, as opposed to 19? So I think that's why I really sort of would encourage that every sort of question or scenario, you at least, you know, preliminarily explore, well, is this really a question this patient can't answer? And some people who have, you know, advanced dementia, bedbound, nonverbal, probably, you know, nothing. They can participate in nothing. But I think this has come more to light just in sort of spending time, you know, in the outpatient setting doing geriatric stuff, is a lot of older adults, even with dementia or, you know, Parkinson's, like, they really can answer a lot of questions and participate in their care to a fairly, you know, decent extent. And we just sort of assume like, well, there's a diagnosis of Alzheimer's in the chart, like we can't possibly engage them in any question. And so I guess I would encourage us to sort of, you know, kind of take it individually. Yeah.
I have trouble when, because I think that family members have a different reasoning of what it means to be someone's power of attorney
Mm-hmm.
than this dynamic
Yeah.
involvement. And so I'll have family members come in and they're like, well, I'm mom's POA,
Yeah.
I'm the one who makes all her decisions.
Yeah.
Is there a different term or something we should keep a lookout for when someone maybe like is in that in-between stage where we actually can't tell maybe like how quickly they're fluctuating between like having capacity and not, and maybe they have had like an actual competency or like evaluation or something that we should know that actually like even if in this moment it seems like grandma wants to go home and she's able to walk safely.
Yeah.
If mom is saying nope, like I'm the decision maker, is there a different type of paperwork we should really look for? Is there another term or version?
Well, I wish there was. I guess so I would say is, so if there's any sort of competent, you know, if the court has said for whatever reason this patient is not competent and has identified someone else to make these decisions or appointed someone from the Department of Aging, I think you really do have to sort of go through them and sort of engage that, you know, decision maker. I think, you know, if it's really sort of in real time and that decision, you know, the patient says, well, okay, I'll stay, and then 5 minutes later, no, I want to go home. I think, which I gets back to communicating a choice. I think there's 2 ways a patient can't communicate a choice in my mind. 1, they like can't talk and they're obtunded. Or 2, they're fluctuating so much with their communication you can't really sort of affect what their request. So if that's the case, like, then I would say they're not effectively communicating. And so that might be a scenario where, you know, the daughter is going to have to be the one to communicate that choice, or, you know, the patient doesn't have capacity. I think sometimes framing it for family, because I agree, I think a lot of people sort of have a misunderstanding, and actually a lot of clinicians have, I think, misunderstanding about it as well, is just sort of framing it as like, it's great you're here, thank you for being here, and so I want to try to come to a decision that works for everyone. While your mom's able to kind of answer these questions, it's really important that we look to her to sort of guide that, and she'll ultimately be the one making the decision, but I want you to be part of that conversation and share with your mom your concerns. And then I think that's sometimes, doesn't always work, but sometimes then they at least feel a bit more engaged, rather than just, no, be quiet, you sit to the side, it's whatever your mom says. Yeah.
How would we know if it had been assigned, I guess, from the Department of Aging or whatever?
Yeah, I don't know that there is any sort of flag or anything in a chart or record. Most of the experiences that I have had is these patients are not coming in with family. There's often an overlying sort of psychiatric or mental health diagnosis. I think a lot, you know, coming in from a nursing facility. Usually if there is someone designated from the Department of Aging, at least in my experience, it's because there's no one else available to do it. And so they wouldn't be coming in with like a huge family. I had a patient during fellowship who was an older adult who lived at a nursing home. She had really bad psychiatric disease and had no family. And so she had a guardian from the Department of Aging for like decades. And so that patient, you know, had she come, she's coming from a nursing facility, that there's no sort of family coming with her. I think the next of kin was actually identified, this woman who had actually been her Department of Aging, you know, contact for like 15 years. It's sort of become her surrogate family as well. So I think, I don't know that there's like a clear flag, but usually I think those patients show up, you know, from a nursing facility, underlying psychiatric disease, not a lot of family, yeah. But,
The comment, I mean, I think unfortunately in the situations where they are guarding the state or the state is their
yeah.
they do not make any life decisions at all. And so that gets really funky
Yeah.
Sometimes there's a lot of utility in what they're doing, and yet the decision maker can't make that decision.
Yeah. No, I think that's true. It's, it is, and sometimes they're a little tough to get a hold of. I mean, I don't know if anyone's sort of been in those scenarios where you can't get a hold of anyone, or they're the decision maker, but they have to go through a bunch of hoops, or they're not really willing or ready to sort of give those decisions, particularly when it comes to end-of-life matters. Which is, I think, all the more reason when patients have the ability to identify a surrogate and to, fill out advanced directives in some capacity, even if it's not like, what would you do in this scenario or this scenario? Just like, who can we look to answer these questions? Like, have social work engaged, just make sure that is clearly documented, because at some point when they can't do that, that's a problem. Cool. All right. Thanks, everyone.
Thanks for,
Sure, you bet. Thanks for coming to the last talk.